Hi, I'm Dr. Sean Panzer, and I'm with North Texas Gastrointestinal Associates, located here in Denton, Texas. The address is 2501 Scripture Street, number 201, Denton, Texas, 76201. My office phone number is 940-566-4720. Fax number is 940-566-4727. Website is www.ntgia.com. Today I want to talk to you about liver disease, and liver disease is really common, and people sometimes when they find out that someone says that they have abnormal liver function test or some kind of finding, they don't always think of them having liver disease, but it is a really common problem. It's one of the more common things that gastroenterologists deal with, and so I wanted to spend a little time talking to you about the different conditions. And again, mainly pay attention to what I'm saying, because this is going to be a kind of a traditional non-electronic type talk, but I think that I can help you sort of become a better healthcare consumer when it comes to getting liver disease investigated, and it'll help you ask better questions when you go to see a gastroenterologist like myself or somebody or another type of practitioner. Okay, the first thing I want to do is explain the normal anatomy like I try to do in all these videos. So when you swallow, food goes over the tongue, comes down this long tube called the esophagus. Your lungs are on either side, your heart's here, your windpipe's here. The food then goes down through what's called the lower esophageal sphincter at the bottom part of the esophagus and into the stomach. In the stomach, the food mixes with acid, gets ground up, and then proceeds into this C-shaped area called the duodenum. That area is important because you have two things emptying there. One is your pancreas, which runs right here behind your stomach. It makes a juice that's important for breaking down food. It also makes insulin, which is important for your blood sugar control. The other thing emptying there is your liver, and it makes a lot of things, one of those being bile. Bile goes into tubes called bile ducts. They come into one main one that goes through the pancreas and out to the intestine. Your gallbladder is attached there and serves to store the bile until you eat, then squeezes the bile in to mix with the food. From there, it goes down about 23 feet of small bowel, during which time nutrients are brought into the body, water and waste is left behind. That comes out in the right lower part of the belly in an area called the cecum. Your appendix is there. As your water and waste goes up the right colon, across the middle, down the left colon, and then makes this S-shaped turn to where it comes out, water's removed, and the stool becomes firm, okay? Okay, so this is gonna be maybe a little bit hard for you to see, but, this may be a little bit hard for you to see, but you probably can zoom electronically with whatever device you're using. And so this is I'm in one of my exam rooms, and these are pictures that I use to explain things to people. And so what's being shown here is the area that I just went over with you, which is the liver. It's here, and your pancreas, your small bowel is here, and and then your gallbladder's here. Your gallbladder's here, and then you see some blood vessels and some other things. So liver is extremely important, and obviously all your organs are, but this one in particular, because it does so many different things for the body. It receives about 1/5 of the blood flow that comes out of your heart. It receives all the blood flow. If you can remember what I just showed you a minute ago with all those abdominal organs, all the blood flow that comes leaves those organs goes through the liver, and the liver has an important functioning or filtering function to get toxins and things out that would probably literally kill you if they were not processed by the liver. The liver processes almost every medication that you take and changes it into a form that allows it to be sent out into the bile and then ultimately the stool. Makes clotting factors 2, 7, 9, and 10. It's involved in cholesterol processing. It actually makes sugar. So when you go like on a keto diet, things like that, the liver will make sugar to help to keep the sugar and makes it out of fat. It is an important part of your immune system, and it just goes on and on. So really important organ, and it's one that's surveyed in your basic blood work when you have your annual physicals and you have what's called a CMP drawn. There are tests that we look at in the CMP. If any of you have looked at your lab tests, you'll see things like total bilirubin, albumin, AST, ALT, what's called alkaline phosphatase, and so these are tests that tell us what's going on with the liver. And so, for example, the AST and the ALT are what are known as transaminases. And so those are actually made by the liver cells themselves, and that reflects injury to the liver. So if you have a drug side effect, or if you have what's called a steatohepatitis, which is where you have fatty liver, and then irritation of the liver, those substances are being released by the liver cells themselves. Then you have bilirubin, which is a breakdown product that is processed by the liver, and it is ultimately pulled out of the bloodstream and sent into the bile ducts, and then down into the main bile duct here called the common bile duct and the gallbladder, and the gallbladder stores your bile until it's needed for when food comes through this area. You have what's called alkaline phosphatase. That's actually made by the bile duct cells and will be abnormal in certain conditions that affect the bile ducts. And so albumin is another substance we measure. Albumin is the most common protein in the body. It's very important in terms of it holds on to things as they're transported through the bloodstream. It's also responsible for keeping water and salt in the blood vessels and not out in your tissues, and is affected by liver disease. And then another one that we'll measure is what's called the prothrombin time, which is a measure of clotting, and that can also tell us how the liver is doing as well. And so a lot of different things can affect your liver, and I'm not going to be able to cover them all because some of them get to real specific and kind of in the weeds, but I want to cover some real common ones. The first one I want to cover is what's called steatosis of the liver. And steatosis is basically fatty liver. Steatosis is fatty liver, and basically what happens is that you have fat cells in your liver, and so when you start to get overweight, your insulin levels usually have gone up. You have what's called insulin resistance, and you have these cells in the liver that are basically fat cells, like you have in the areas that you can see in your love handles, and your rear end, and abdomen, that kind of thing. So the fat starts to deposit in the liver, and like I said a little while ago, it's a really common problem. Probably 5% of people with normal weight will have a steatosis. Approximately 50% of people who are obese or overweight will have it, and 100% of people who are morbidly obese will have it. It's also common in some metabolic conditions such as diabetes, particularly when the blood sugar control is not good. About half of those people will also have inflammation in the liver. In other words, when you look under the microscope here, you see inflammatory cells, white cells, in other words, that are also mixed in there. And so when white cells are present, they're doing something. They're not there just to kind of check things out and make sure everything's okay. Their products are being released, and the products that white cells release are toxic. They're meant to break things down and to clean things up. So that irritates the liver. As in any other part of the body, when you have inflammation or you cut yourself, you lay down scar tissue as part of the repair process, and that can happen in the liver as well. So when I came out of training back in the 90s, it was thought that fatty liver was no big deal, that it's just like a normal variant. But we now know that fatty liver is actually can lead to cirrhosis, just like hepatitis C or drinking too much alcohol can. So it's a problem that can go on to more serious consequences, including cirrhosis. Up until this time, hepatitis C has been a leading reason for liver transplantation, but now we know that probably in about 2020, that fatty liver disease will be the most common cause for liver transplantation. As with most things, or maybe all things, there's a genetic component to this. There's a gene called PMPLE, which seems to be involved in fatty liver, that's been identified in fatty liver pregnancy, actually. And but again, there hasn't been any specific genetic test or anything that's of clinical relevance at this time. So the treatment for steatosis, first of all, in the workup, we can find the fatty liver by ultrasound. That's a good way, but it doesn't quantitate how much fat is in the liver or tell you how much scarring is there until you get a very advanced problem like cirrhosis, which then will show itself through changes in the contour of the liver in terms of how that looks. There's an MRI test that does do that, but MRI is very expensive, and it's also difficult to do a good MRI. It's a lot of people don't like it because it's such tight quarters and you get kind of claustrophobic, and so it's not, it's expensive and a little bit, probably a little bit of overkill in terms of workup of this. There's relatively new technology that's called FibroScan, and we have that here in my office. With FibroScan, what we do is we put a probe on your side between your ribs, just kind of right over where the liver is on the right side, and it basically thumps the side, and so that sends sound waves across the liver, and we can measure how fast those sound waves are traveling, and that corresponds with how stiff the liver is, which is a measure of what everybody is pretty much accepting as a measure of the amount of scar tissue in the liver, and so we can quantitate that. We can also quantitate how much fat is in the liver. So we grade that according to how much we see on the study. And so it can be very helpful. For example, if there's a person who's not diabetic, and then we find that they have fatty liver, that they have scarring, then we will be more aggressive in terms of working that up. So in other words, we might get an insulin level to make sure the person's not pre-diabetic, because we know that some medications, such as metformin, another one called Actos, which is known as pioglitazone, can be helpful in this. Also, some of the cholesterol-lowering medicines can be as well. And there's some clinical trials that are now coming out looking at investigational medications that can help with fatty liver and also with weight loss. So that's how it can impact that. So when you look at in terms of actually having to do liver biopsy, we usually don't have to do liver biopsy for this, although in some cases we might. When you look at the treatment, of course, weight loss is very important. Also, vitamin E, 400 units twice a day is something that I use. It's been shown to probably improve liver histology and also reduce the amount of fat. Again, it's not a just 100% response rate or anything like that, and it's still kind of built on shaky literature. But vitamin E is a mild blood thinner, but otherwise is not a problem if you take the right amount. Then you have, of course, you get your weight loss. You also want to abstain from alcohol, because you don't want anything that adds additional damage to your liver, additional insult to the liver, is not something that you want to do. And so, again, what's the safe amount of alcohol? Well, I mean, it's almost certain. Most people would agree less than 2 drinks a day. But if you have another problem, I would definitely abstain from alcohol. You just don't want to add anything in addition to what's already going on, no matter what the underlying liver condition is. And then, of course, if you are diabetic, then you want to keep your blood sugar low as you can, as close to normal as possible. It's very important, because the high blood sugar affects everything. It affects your cardiovascular system, it affects the liver function, and it affects your kidneys, your cerebrovascular system. All those things are affected by diabetes, so you want to keep that under control as well. We do not usually use medications specifically for fatty liver. We don't usually put people on metformin. We don't put people on Actos or atorvastatin or any of those drugs specifically for this. But if you're on them for other reasons, then it can be beneficial as well. Okay, the next thing I want to talk about is alcohol. I'm not going to spend a ton of time on this, but obviously alcoholic liver disease is really common in this country, and it's common all over the world. And I think on the BBC I heard that it's like 5% of the entire medical expenses of the planet are related to alcohol. So it's a really common problem. It's something that alcohol is kind of socially acceptable, but it has consequences all over your body. In regards to the liver, when people are told that they have cirrhosis, the first thing they'll say is, well, I don't drink. And that's, a lot of times it's true, but a lot of times people have misconceptions about what too much alcohol is or what alcohol is. So a lot of people, think that alcohol is just like, Jim Beam and whiskey and this and the hard liquor, but that if you drink beer or wine, that's somehow better. And it's actually about the same. 1 glass of wine has the same amount of alcohol as 1 can of beer and 1 shot of liquor. And so they're all pretty much the same, and the way they're handled by the liver is no different. Whether you drink red wine, white wine, or Moscato, or you drink liquor. And so there's no way. All of us know that, as well with smoking, that Uncle Johnny smoked 80 years and drank everything he wanted, and lived to be 100. Okay, that's great. There's some people that have awesome genetics and they bodies can handle that, but a lot of people cannot handle that kind of stuff. And so when you look at most of the forms of chronic liver disease, the chance of going on to cirrhosis is roughly about the same. It's about 1 in 5, whether you're talking about fatty liver or you're talking about hepatitis C or you're talking about excess alcohol. And I would just say that alcohol is a direct toxin to the liver. In men, I don't have the picture of the stomach, but in men can have what's called alcohol dehydrogenase in the stomach, and so they process alcohol a little better. That's at least the way I was trained on this. And whereas with women, all of it has to be processed by the liver, but the liver processes a lot of it for men as well. So it's a direct toxin. And so over time, it's not something that gives you immediately, but if you look over a period of 30 years or so, that's when you start seeing problems. So you get into my age group, I'm in my 50s, that's when you start seeing problems, or you might see it earlier depending on the person or how much they've been drinking. But really, a safe amount of alcohol, I think, is really no more than two drinks a night, whether you're talking about beer, wine, or hard liquor. And so again, and that's just alcohol. If you have you're on medications that can affect the liver, if you're on a number of other things that make you more prone to liver disease, family history, something that you don't know about, those things all add on to, are synergistic with alcohol. So that can all be an issue. So again, we can only control what we put in our mouths, suck into our lungs, and the physical fitness that we maintain. And you still can have things happen. And so anything you can do to protect your body from harm is important. Obviously, everybody knows how you stop. You deal with alcohol. You stop drinking, and so that's the importance. But again, when the liver starts to be harmed over time, probably about about 1 in 20 chance or about a 20% chance of developing cirrhosis. Again, some people could argue with those numbers, but I think that's pretty accurate. Okay, the next thing I want to talk about is hepatitis C. And as I said, hepatitis C, steatosis are running neck and neck in terms of being indications for liver transplantation in this country. So a very common problem. Hepatitis C is a virus, is what's called an RNA virus, and it is something that's transmitted through intimate contact. So it's blood transfusions, which since 1992 we've been able to test for this, so that's not an issue any longer. But exchange of blood, exchange of body fluids, this kind of thing. It's not passed on by, at least we don't believe, passed on by casual contact. About 30% of people, though, will not know exactly where they contracted hepatitis C. So again, that always makes you wonder if there's something else. But again, it's felt to be intimate contact type of transmission pattern. And so with hepatitis C, you usually don't get symptoms when you get the virus. So if you get hepatitis A, you're almost always going to be jaundice. Same thing with hepatitis B. Hepatitis C, the vast majority of people that I've seen who have it don't remember when they got it. They can date it back to risky behaviors such as risky sexual behavior, IV drug abuse, jailhouse tattoos, weren't done with clean needles, things like this. They remember those periods of time. But they don't remember ever getting jaundice or having tea-colored urine or real light-colored stools or any of that kind of stuff. So they just kind of go around with this, and that's what makes it kind of dangerous, is that it can be transmitted through these sexually risky behaviors such as unprotected sex. And so it's why it's been able to spread so completely. But basically, the virus itself, at any one time, infects about 5% of the liver, and then over time, it will be released out into the bloodstream, and then it'll come back and it'll infect new livers or new parts of the liver. And so the virus itself doesn't actually cause so much of a problem. It's the immune system response to that. Your immune system recognizes that it's there, and it attacks the liver. And so as these liver cells are infected and then they're cleared out by the immune system, then the scar tissue is laid down, and that process is just repeated over and over and over again over time. And so when you look at people who've had viral hepatitis for about or have hepatitis C for about 30 years, probably about 40 to 60% of them will have what we call chronic hepatitis, meaning that the liver tests are high and the person has fatigue. They may have other things such as muscle aches, joint aches. They might even have symptoms related to what's called cryoglobulinemia, where you deposit immune system complexes in joints. That gives you that. You can have skin conditions, what's called porphyria cutanea tarda. But many times people are just are found because of the abnormality in their liver function test. And so the vast majority of people are walking around not having any symptoms, that kind of thing. Over that 30-year period, probably about 20% will develop scarring of the liver, which is, or cirrhosis, in other words, and the various consequences of that. And so the testing that we can do nowadays is very good. You have your initial liver function test, you talk to the person about possible risky behaviors, and then you do testing which allows us to look directly for the virus. So it very precise, what's called polymerase chain reaction based test. And so we can tell you have that. Then if you have the hepatitis C, thankfully, we now have treatment, and we've had treatment for a while, but the treatment has been horrible. Over my career, I've seen the full evolution of this. We went from 3 times a day interferon, which cured about 15% of people. Then we got the longer acting interferon, which cured maybe up to a third or so. And then we had ribavirin added in, and that increased it. And then we added in a third drug with long-acting interferon and got it up to about 60 to 70%. And then we had the direct-acting oral medications which became available, and they've just been amazing. I mean, they're extremely expensive. They can be up to like $1,000 a pill, but treatment is like 8 to 12 weeks, and the cure rate is amazing. It's 95%, and it's just a totally different type of therapy. In the past, we used to have to do liver biopsy because we wanted to know how much scarring you had, so that we could monitor more carefully and make sure that if you're progressing on the cirrhosis, that we had that addressed to the best extent that we could. But nowadays, you don't need that. You can do FibroScan, which I described a little while ago, which allows us to determine how much scarring you have. There's also a blood test called FibroSpect, which where we can kind of get the same information. But I think FibroScan is the way to go on that. And so it's just a totally different disease. And so it's also thought in the old days, we thought that once you laid down scar tissue that you didn't that did not reverse, that it was permanent and that was it. We now believe that to some extent this will reverse, and that's true for all liver disease because the liver is very resilient and can regenerate itself. But again, you're definitely, if you've had 30 years of hepatitis C, you're not going back to the way your liver was when you were 18. So, but the treatment is much better. The most important thing is that if you have hepatitis C, I think that it's one of those diseases that you don't pass by casual contact. But you definitely don't want to be sharing your razors. You don't want to be sharing toothbrushes. Anything that could lead to an exchange of blood. You should be having protected sex. Sometimes we encounter people where the one spouse has hepatitis C, the other one does not. And when you look at older data on this, you have about the unaffected spouse has about a 17% chance over 20 years of contracting the virus. So obviously nowadays you really want to get treatment. And like I said, it's a totally different disease, and it's dropping off as the leading cause of liver transplantation in this country. If you have hepatitis C along with other viruses like HIV, then that can be more aggressive disease. If you have any form of liver disease, you should make sure that you check your vaccination status on hepatitis A and hepatitis B, because if you contract another virus on top of something like hepatitis C, it can be much more serious with much more damage than you would have had otherwise. And again, same thing. If you have hepatitis C and you drink alcohol heavily, you're a heavy alcohol user, or you have fat in the liver, these things all add together to increase the injury to the liver. The next set of disorders I want to talk about in regards to the liver is the subject of viruses other than hepatitis C. And there are a number of viruses that can affect the liver. Of course, you have hepatitis A, which is a virus that's spread by what we call the fecal-oral route. And someone who is shedding the virus usually will be involved in some kind of food handling, something like that, or a person just picks it up from another individual. And so you have a short period of time between exposure and subsequent development of symptoms, and you almost always will get symptoms. You'll turn yellow, and it's a condition which is self-limited and very low risk of having liver failure, and then you become immune to the virus. So there's no chronic state chronic liver disease that's linked to hepatitis A. Then you have hepatitis B, and also importantly, there really is no treatment for it other than supportive care, and the person can be vaccinated to prevent that, and I recommend that to people. It's particularly important that you get that vaccination if you have other forms of liver disease, because if you have, let's say, like hepatitis C, and then you pick up hepatitis A on top of that, then you have a higher chance of liver failure and significant consequences in terms of your liver disease. The other virus is hepatitis B, and hepatitis B has a transmission pattern that's similar to hepatitis C. So it's usually exchange of body fluids, sexual contact, blood transfusions, which of course the blood supply is now safe because of testing in that regard, intravenous drugs, tattoos with unclean needles used by other people, and of course, as I said, risky sexual behavior. It's your ability to pick up hepatitis B is actually pretty good. It's pretty easily transmitted, and the same thing, people will get will usually get symptoms. It usually is a little bit longer a time period between exposure and the hepatitis B. Probably about 90% of people who get hepatitis B will become immune. The thing about hepatitis B is that it's a DNA virus. So what happens is that when it goes away, it actually integrates into your DNA, and so it's there, and so it can come back later on if for some reason your immune system is not becomes suppressed, like if you develop HIV or you have cancer, chemotherapy, total body irradiation, stuff like this. So that's a virus that can come back. So 9% of the time your immune system will get control of it. About 10% of the time it will not, and so you have ongoing hepatitis B. And hepatitis B, again, has that transmission pattern. It's also really common in certain areas of the world, like Africa and Asia. And so when people come in, and the number of authorities actually recommend that people who are from those areas and immigrate to the United States should be screened for hepatitis B. In about 10%, the virus is not controlled by the immune system. And so what happens is, of those people who have ongoing hepatitis B, liver function tests are elevated, and they have a certain amount of virus, then they actually have a pretty high chance of going on to developing cirrhosis, which again is scarring of the liver and ultimately possibly liver failure. And so the virus, if we find people like that, then we treat them. The treatment is really good treatment. It's oral treatment, but it's not curative. Only about 3% of people will be cured. The other people, the virus will become undetectable, but over time, people can have the virus recur, and they will need a rotation to other medications, interferon and various other things. And so about maybe up to 50% of the people who don't get control of the hepatitis or who are not treated can develop cirrhosis. So the cirrhosis rate is much higher with hepatitis B than it is with hepatitis C. Other viruses can affect your liver too. One of the more common ones is actually Epstein-Barr virus, which causes infectious mono. And so usually with that, it's part of the acute illness. It's about the time you're getting the throat symptoms, you can develop a big liver, and you can also develop a big spleen. And so it's usually not thought that it goes on to a chronic state, but it can be a problem at the time. And as people probably know, if you have a large spleen with infectious mononucleosis, you have to avoid contact sports, so the spleen, you don't have the risk of splenic rupture. Another virus you may run into is hepatitis E. This is seen in pregnant women. We don't see that so much in the United States. And then I read recently there was a type of rat hepatitis virus. I think it was kind of like related to E, which has mutated and has infected people. I think it was in Africa, but I haven't read that in my literature. That was through the media. So those are the main viruses that we deal with. The next set of disorders I want to talk about are diseases where the immune system gets overactive in the liver, and there are three main ones. One's called autoimmune hepatitis. The second is called primary biliary cirrhosis, and the third is called primary sclerosing cholangitis. And so with autoimmune hepatitis, what happens is it's kind of like a relative of autoimmune, these other disorders that you see where the immune system is overactive. So autoimmune thyroiditis, which is called Hashimoto's disease, lupus, where you have immune system is overactive against the skin, rheumatoid arthritis, where it's overactive against the joints. So these are diseases in which there's an imbalance between the part of the immune system that does things, that's active and getting rid of bacteria and getting rid of cancer cells, and the part of the immune system that controls the activity of the immune system. There's an imbalance there. And so in autoimmune hepatitis, what happens is that the immune system actually attacks the cells themselves. And so usually the person doesn't know this is going on, and they have abnormal liver function test. And one of the things you can see on your basic blood test is that when you look at the globulin to albumin ratio, these are two proteins that are measured in your basic blood work. The globulin component is high, and so that tells us that you have immunoglobulins floating around for some reason. And so that can be suggestive. Usually the ALT is higher than the AST. If you look at your own labs, those are the transaminases. And so over time, and the liver tests are usually not dramatically elevated. They're usually in the several hundreds, 200, 300 range. But over time, as the inflammation goes on, just as in other parts of the body, you lay down scar tissue, and over time, the liver is eventually compromised, and you have less and less functioning liver and more scar tissue. So it can go on to cirrhosis. And so we will make the diagnosis by additional blood testing, and then sometimes you need to do a liver biopsy. That may be changing, I think, but liver biopsy where we see what are called plasma cells, and so the diagnosis is made. Fortunately, the treatment works really well, and so usually you put on a medicine called prednisone, which is a steroid that controls the immune system, and a drug that's called Imuran, which is used in other disorders, and is an old cancer chemotherapy drug, but in low doses is very good for this. So usually you get on both of those medications. The prednisone will be tapered off, and then you remain on the Imuran. And so, but it will usually respond. But it's difficult to know when you can come off that. It's generally said that if you're going to take a person off therapy, you need to repeat the liver biopsy to make sure that the disease is completely gone, because the blood tests are not that accurate in terms of reflecting what's going on in the liver. The second condition is called primary biliary cirrhosis, and this is a disease where the immune system is attacking the bile ducts. And so it's not these big bile ducts as you see here. This is the biliary tree outside of the liver. It's actually small bile ducts that are in the liver itself. And so same thing, usually you don't have symptoms, although sometimes people with more advanced disease will come in with itching, and they may even come in yellow. If that's the case, that's usually an advanced situation. But usually abnormal liver tests, and so there's one that's called anti-mitochondrial antibody. We check that, and that's going to be positive, probably more than 90% of people, and the vast majority of people with this disorder and autoimmune hepatitis are going to be women. And so the treatment for that is actually a really quite a good treatment. It's to use a synthetic bile salt. There are two of them. One's called Actigol, the other is called Urso, and it basically just it decreases the inflammation. But the reason that this can also go on to cirrhosis is because when you have the inflammation around the bile ducts, that inflammation extends out into the tissue of the main substance of your liver, and again, it's the same process. Once those immune system cells are there, they tend to hang out, release substances that cause problems and damage to the tissue, and scar tissue is laid down subsequently. But I have a number of people in my practice with this, and it's usually well controlled by that simple medication. Another condition is called primary sclerosing cholangitis. And it's kind of like the primary biliary cirrhosis, except that it's also in these big bile ducts here. And so typically, again, same thing. You'll have abnormal liver tests, or you may have a CAT scan or ultrasound, which shows that the bile ducts are dilated. And then when you go in with a procedure, either what's called MRCP, which is an MRI of the bile ducts, or ERCP, which is the endoscopic variety of that, then you see these narrowings in here. And there's no particular blood testing for it. But we do know that about probably 5% of people who have what's called ulcerative colitis, which is a situation where the immune system's overactive against the colon, about 5% of people with that disease will develop this primary sclerosing cholangitis. But people with sclerosing cholangitis, probably 70% will have ulcerative colitis. So if this is found, then the colon needs to be looked at as well, because those people also have a higher risk of developing cancer. Unfortunately, there's not really any specific treatment for that. So if you developed a dominant stricture, a dominant narrowing, doctor can go in and put a stent across that and open it up with a balloon dilator, and obviously take samples to make sure it's not a cancer, and that's the way we usually manage it. But all those conditions can result in liver transplantation. So if you're diagnosed with any of those things, you really need to keep in contact with your doctor. So the next disorder that we'll talk about is, let me start over. The next disorder we'll talk about is hemochromatosis, and then afterwards will be a disease called Wilson's disease. And both of these disorders get us a little bit into the weeds of hepatology, which is the study of liver disease. But I want to mention them because they're part of a broader set of disorders in which things get abnormally deposited in the liver. So we talked earlier about how fat can do that with steatosis, and then the subsequent problems that can develop. But you can have other substances that develop or that deposit in the liver as well. And one of those is iron. Now, iron is all of the minerals are very important, and they are used by the body in very small quantities, and they're also very tightly regulated. So in the case of iron, it is very tightly regulated, not really at the level of the liver, but actually at the, not sure if you can see this, but on the level of the small bowel. That's where iron is absorbed. It's absorbed in the duodenum. And so it's very precisely regulated, because there's no way for the body to get rid of iron. The only way it gets rid of iron is through the shedding of the cells of the intestinal lining. And so the iron is actually regulated at the kind of at the bottom of the small intestinal cell, and the substance that actually regulates that comes from the liver. It's called hepcidin. And so in hemochromatosis, it's a genetic disorder in which the person absorbs too much iron, and it's very common actually. It's present. It's thought that it could be present in as many as maybe 1 in 250 Americans, and so it's one of the things that it's been argued that we should screen for it because the gene is so common. But right now we don't really do that. But in people who have abnormal liver function tests, we do look for it. We look at iron studies so that we can tell if the person has high iron levels, and then proceed on to the workup. But basically, like I said, it's a condition in which you absorb too much iron in the body, and it's clinically silent, usually until you get to your 40s and 50s for men, and then about a decade later for women. And that's because women are protected because of menstruation, so they're losing iron until they go through menopause, and then things start to occur after that. But the 3 areas that can give you, well, maybe 4 areas where you can see signs of this are the liver, and then also the heart and the pancreas. And so you can get what's called bronze diabetes related to diabetes. And some people will also get joint pain and arthritis type symptoms, not because of deposition of the iron, but because of other minerals that crystallize in the joint space. And so basically what happens is that, and iron can accumulate in your liver for a number of reasons. One is alcohol. Alcohol facilitates iron absorption, and it tends to deposit in the liver. Also, you can see this in conditions like inflammatory conditions like hepatitis C. But in those situations, the iron actually deposits in white cells in the liver, what are called Kupffer cells. And so they deposit there, whereas with hemochromatosis, the iron is actually accumulating in the liver itself. Iron is a very active, chemically active substance, and as a result, it can damage the liver. And so when one of the consequences, just like with all these other things we talked about, is the development of cirrhosis. Usually you also get problems with the heart. The heart may fail, and also, like I said, the pancreas. Eventually you can get diabetes. And so a person can go on and develop cirrhosis as a result of that. It's also one of the conditions, I haven't said a lot about this, but anytime you have cirrhosis, you have an increased risk of liver cancer. And hemochromatosis is probably the one condition that really increases your risk of getting liver cancer. And so it's important to find it, because if we find it early enough, then we can actually treat it by simply eliminating the conditions where you may be absorbing too much iron, like alcohol use, or taking supplemental iron, or taking iron with vitamin C. We can certainly do things to limit it, but you can also treat it with phlebotomy, just withdrawing blood. And so when you take a pint of blood, it's about 250 milligrams of iron. And usually when we find hemochromatosis, you already have an excess of about 5 grams of iron. So if each unit of blood takes off 250 milligrams, you obviously have a lot of phlebotomy ahead of you to get the iron levels down. And so the diagnosis is usually made initially through iron studies, and then we look for the gene itself. There are two genes, C282Y and then H63D. But there are also some other conditions in which there are some forms of hemochromatosis where we cannot measure, or we cannot take blood check blood tests which tell us the exact gene that's involved. And so it's one of those things where you really have to be sure, and that's usually by getting a liver biopsy and seeing the iron depositing in the liver cells itself. So that's usually the way we'll diagnose it. You can also probably diagnose it by MRI because we can actually quantitate how much iron is in the liver. But again, it doesn't tell us if it's in the liver cell itself or in the white cells in the liver. And so, like I said, treatment is phlebotomy. Usually the target will be to get the what's called the ferritin level, which is a measurement of your body's iron storage. We'll get the ferritin level less than 50 and keep it there. But a person with hemochromatosis needs to have surveillance for liver cancer, because even without cirrhosis, you have an increased risk of liver cancer. And so ultrasound and a tumor marker known as alpha-fetoprotein will be checked. Wilson's disease is a very uncommon condition. It's also a genetic problem in which you absorb too much iron. And so the person, usually it's a person who's less than the age of 40 in whom that'll be diagnosed. Again, liver disease, abnormal liver function tests are part of that. Also, a person will get an unusual eye finding called a Kaiser-Fleischer ring, and then also they many times will have psychiatric abnormalities. But usually that's a disease of younger people. And again, same thing. We have ways to specific drugs like penicillamine and even zinc, which we can use to reduce the amount of copper that's being absorbed and how it's affecting the liver. The next thing I want to talk about is not really what I would consider a liver disease, but two liver findings which you will encounter when your doctors do CAT scans and ultrasounds. And the two things are what are called liver cyst and hemangiomas. Both of these are basically normal findings. A liver cyst is kind of like a fluid-filled bubble, like what you see in Swiss cheese, or the holes that you see in Swiss cheese, and that's pretty much how they look. On a CAT scan, it'll be just a little dark area. On the ultrasound, it will be an area where the sound waves pass through very easily, suggesting that there's water in there. And they really have no clinical consequence. We don't do surgery on them. They don't have cancer potential. But if they get large enough, if they're at the edge along what's called the liver capsule, then sometimes they may require treatment, surgery, injection of substances to make them scar down. But I see them all the time, and it's extremely rare that we have to do anything with them. Liver hemangiomas are probably the most common normal finding that we see on CAT scan, routine radiography of the liver, and they basically represent areas where you have abnormal, almost like a little ball of blood vessels. And kind of a related finding is something you see on the skin, what's called a cherry angioma or cherry red spot, and it's kind of like that. And so again, these are normal findings. They don't go on to become cancer, and they don't become, generally speaking, they don't do anything. They don't become larger. They're not a cause of pain or anything else. The other thing I want to mention is just the idea that your liver can cause pain. The liver actually has very few, a very limited nerve supply, and it's to the capsule of the liver, what's called Glissen's capsule. The substance of the liver itself, when you do liver biopsy, you don't see nerves inside the liver. And so the liver really doesn't give you, is not really a source of pain unless you have a major problem. You have major trauma, you get a liver biopsy and you get bleeding below the capsule of the liver, which you almost always do. Motor vehicle accident, trauma, surgery, things like that. Now, I have seen some people where the liver is very large, and so you can almost imagine that the liver is being stretched out, the liver is not the shape that it normally should be in, that's going to have some kind of consequence. And I do occasionally see people where I'm pretty sure it just seems like that's the source of the problem. But again, it's not something that we usually have to do any kind of treatment on or anything like that. Okay, so I've zoomed back in on a picture, and I just want to talk about one last thing in this lengthy video, this lengthy survey of liver diseases. And that's this right here, which is called cirrhosis. So this is what your liver is supposed to look like, and this is what your liver looks like when you have cirrhosis. And what you're looking at here is you see these dark bands. These are actually bands of scar tissue, and then you have this lighter colored nodular tissue here, and that's actually the normal part of the liver. And what's happened here is that you've lost a lot of your normal liver function, and so the remaining normal liver tissue actually grows. And the liver is really amazing, because if the liver is healthy like you see here, and you have some reason that a large chunk of or a large part of the liver needs to be removed, you can remove up to 70% of a normal liver and it'll grow back to its original size. But when it gets like this, obviously it's not going to be able to do that. And so this is the end result of all the things that we've been talking about, from the steatosis all the way down through the metabolic liver diseases like hemochromatosis. And this is what we're trying to prevent. Once you get to this point where you have cirrhosis, your chance of being alive, it's still pretty good, amazingly. Your chance of being alive 5 years subsequently is about 90%. 10 years is about 80%, and that includes all diseases. Probably about 5% of people well, let me put it this way. Obviously, when your liver scars down like this, you are at an increased risk for a number of things. One of those is liver cancer, which is known as hepatoma. And this, it just kind of follows what happens in the other parts of the body. When you have chronic irritation, lots of biologically active chemicals are being released, and those interact with cells and damage DNA. And so you just by random hits, you will inactivate what are called tumor suppressor genes, and you'll activate what are called oncogenes, and this leads to uncontrolled cell growth, which is cancer. And so when you look at people with hepatitis C, for example, there's about a 5% chance of developing liver cancer, but that doesn't happen until you actually have cirrhosis. In other conditions like hepatitis B, you can get liver cancer without cirrhosis. In hemochromatosis, you have a high rate of liver cancer. So, but that's one of the consequences of developing cirrhosis. Another one, of course, is that the liver exists at a low pressure. So the typical pressure in a normal liver is about 5 millimeters of mercury, as compared to your blood pressure in your arm, which is about, normal is around 120/80. So much a very low pressure system. And so when you start scarring down the liver like you see here, you have the same amount of blood, all this blood coming up out of the intestinal tract, plus 20% of the heart output. It's all coming to the liver. That same blood volume's got to get through a smaller and smaller, a reduced number of channels. And when that happens, you build up the pressure. One of the consequences is that the fluid can actually start to leak out of the surface of the liver, and that goes out into the abdomen, and that's what's called ascites. When that happens, at that point, you have about a 50% chance of dying within 2 years. The other thing that happens is that you have all this blood coming up, and you'll see it on this picture, coming up and ultimately leading into what's called the portal vein, which provides about 70% of the blood flow that goes to the liver. And that vein is formed by by a big vein coming out of the intestinal tract called the superior mesenteric vein, and what's called the splenic vein, which is coming out of the spleen, which is behind the stomach over here, coming this way. And so when you start backing up that pressure, you can get the ascites. The other thing that happens is that you back the blood's got to get back to the heart. And so if you've created this dam here, then it's going to find other ways. And so one of the ways it goes is back through the upper part of the stomach, and that can lead to these little tiny veins normally swelling. And once they get to a certain pressure, usually about 12 millimeters of mercury, then they can rupture. And then you can also have what you see right here, which are called esophageal varices. And these form in about a third of the people who have cirrhosis, and upwards of maybe 2/3 will have bleeding from those. And these are devastating bleeds. These are high volume bleeds, and that carry a high risk of a person dying. And so you have that can happen. Then you have when this blood can't get through the liver filters out all the poisons and toxins coming up out of the intestinal tract. When this damage is created, then you have what's called shunting, and so the blood will kind of get through these areas or around the liver and get back to the main bloodstream without being cleaned up, and so that can lead to what's called encephalopathy. And so all these things are consequences of the liver not working, and it's a miserable existence. It is something that nobody wants to go through, and it is horrible. And once you get to this point, if you get to a point where you have a lot of bleeding, you're having the encephalopathy, all these different things, your liver's failing on you, then your options are very limited. I mean, there's what's called liver dialysis, but that really just hasn't really worked like it certainly hasn't worked as well as kidney dialysis does. And then you're looking at liver transplant, and believe me, you have to get really, really sick before that happens. And so the reason I mention this to you is because liver cirrhosis, liver failure is really not pleasant, and you build up fluid. You have to get on a lot of medications to treat these various problems I mentioned. I'll get into that maybe in another talk, but it's just you just don't feel well, and it's a really horrible thing to do. So bottom line is you want to get better. You want to get better and take care of these conditions early on. You want to get your hepatitis C treated. You want to get control of fat in the liver. You want to do everything you can to keep you from getting to cirrhosis, which again, with scar tissue, we used to think that it never reversed. We now know it does. But when you get to this, you're not going to get a normal liver back. So it's very important to try to do the things, control the things that you can control. So that concludes our discussion on liver disease. I know it's an exhaustive, long video. I'm going to pick individual topics and do videos later on. Thanks again for your attention, and I hope this was helpful. And my goal in doing these is to help you become a better consumer of your healthcare dollar, and to be able to ask hopefully more informed questions about liver disease and the other things that we've done videos on. Again, if you'd like to see me, I'm it's North Texas Digestive Diseases. My phone number is 940-566-4720, fax 940-566-4727. Our address 2501 Scripture Street, number 201, Denton, Texas 76201. Website www.ntgia.com, and I wish you the best of gastrointestinal health.